Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from OTSCA.
This program is presented by Medscape Education Global.
Hello and welcome to this program on navigating the challenges of IgA nephropathy management, the clinical implications of emerging therapies targeting the B-cell pathway. My name is Lisa Wilcox and I'm a consultant nephrologist at Cambridge University Hospital in the UK, where I lead our primary glomerulonephritis service. I'm delighted to welcome Dr. Pei Chen and Dr. Keiichi Matsuzaki to our discussion today. To get started, could you each tell us a little bit about your background and your interest in this disease area?
I'm Pei Chen and honored to participate in this discussion. My primary field is IgA nephropathy. With extensive experience in its treatment, I'm also actively involved in clinical research, participating in several clinical trials of novel therapies.
So my name is Keiichi Matsuzaki. I am a nephrologist with a particular focus on IgA nephropathy. Also, my expertise extends to epidemiology. I possess extensive knowledge in observational studies and database research.
Thank you. Great. I'd like to start by framing our discussion around IgA nephropathy, highlighting its global scale, how it presents, progresses, and shapes the lives of those living with it. It's impossible to start a talk on IgA nephropathy without stating it's the most common cause of primary glomerulonephritis worldwide. It's a slightly different disease in Caucasians and East Asians. So in Caucasians, it affects twice as many men as it does women, whereas the sex incidence is equal in East Asians. We can also see that the incidence increases as you move from west to east and as you move from south to north, and this reflects genetic differences in the disease. In terms of the clinical features, at presentation, almost all patients with IgA nephropathy have hematuria, and many are hypertensive. Proteinuria is present in just over half. And what's really worrying about IgA nephropathy is that more than 40% of patients present at stages 4 and 5, so relatively late in their disease course. The diagnosis is made on a kidney biopsy, and here you can see under light microscopy the mesangial hypercellularity and endocapillary proliferation that we often see in patients with IgA nephropathy. You can see the endocapillary proliferation here in this glomerulus. If you use immunohistochemistry or immunofluorescence, you can see IgA deposition as shown here, and that's really the thing that allows us to make the diagnosis. But as well as IgA, we see C3 present in more than 90% of kidney biopsies. In terms of the pathogenesis of IgA nephropathy, the key factor in causing the disease is a problem with IgA molecules. So IgA molecules in patients with the disease lack galactose residues, and this results in triggering the immune system to develop IgG molecules towards these IgA molecules. This is the HIT1 when we talk about the 4-HIT hypothesis of IgA nephropathy. HIT2 is where you have these circulating immune complexes where the IgA and the IgG that's directed against them come together, and these immune complexes then deposit in the mesangium of the glomerulus, causing inflammation, and this is HIT4 in the IgA pathogenesis. So let's turn our attention to key challenges in today's IgAN management. Pei, what would you highlight as the current standard of care, and where are we falling short?
When we talk about the care standard care, we start with the supportive care. According to KDIGO Guideline 2021, the supportive care includes good blood pressure control and the maximum dose of RAS inhibitor and address cardiovascular risk and lifestyle modification. Among all above strategies, the RAS inhibitors serve as the cornerstone of supportive care. The previous studies indicated that RAS inhibitors reduce the risk of renal progression.
Thank you very much. So we've had this approach to IgA nephropathy for many years. Would be that study you just showed in IgA nephropathy was published sort of 20 years ago. And so we can now see what the outcomes are like for this approach to IgA nephropathy. And there's been a number of registry studies published which have shown us the outcomes over the last 20 years or so for patients with IgA nephropathy. The first and one of the largest of these is the RADAR study, which is the UK National Registry of Rare Renal Disease. Here, more than 2,000 adults and children with IgA nephropathy, where their outcomes have been documented over time. These are all patients with proteinuria of more than 0.5 gram per day and an eGFR of less than 60. And what is really striking about this cohort is that the median age of diagnosis was just 45. And they all presented relatively late in their disease course. So at the point at which they presented, even if we'd managed to slow their eGFR slope, so they're just losing eGFR at 1 ml per minute per year, which is what we expect for the general population, then 40% of adult patients with IgAN would progress to kidney failure within their lifetime. And this is shown nicely here on this plot of eGFR slope. So you can see that patients in their 40s and 50s, if they're losing just 1 ml per minute of eGFR, 40% of them will progress to end-stage kidney disease. If they're losing 3 ml per minute, then 90% of them will progress to end-stage kidney disease. And at 3 ml per minute, if they're presenting in their 30s and 40s, again, all of them will progress to end-stage kidney disease. So we've got a long way to go to improve outcomes in our patients. What was also striking from the RADAR data is the proteinuria data, so that we already knew patients with lots of proteinuria did badly. But what was striking in the RADAR data is that those patients who had low levels of proteinuria, so even those who had less than 0.4 grams per gram of proteinuria, more than 25% of them were progressing to end-stage kidney disease by 15 years. So the 2021 guidelines in terms of management of IgA nephropathy are still leading to a lot of people progressing to end-stage kidney disease. So the RADAR group, most of those patients weren't treated with prednisolone or immunomodulatory agents, but in the 2021 guidelines, there was consideration given to introducing glucocorticoids for certain patients who would be able to tolerate these drugs which have quite a lot of side effects. So if we're thinking about data on the use of prednisolone in these patients, we can look at the testing trial, which was published in 2022, so actually after the KDIGO guidelines were published. And this showed that using methylprednisolone for treating patients with IgA nephropathy could significantly reduce their renal progression. However, this came at quite a cost, and when the testing trial was started, it was actually finished prematurely because of the high number of serious adverse events that patients were suffering, particularly infections. The testing trial was then restarted at the lower dose of methylprednisolone, so just 0.4 grams per kilogram per day. And there, with that dose, we saw the same benefit in terms of renal progression, but fewer side effects. But nonetheless, prednisolone, even at that dose, patients do accrue a lot of side effects and patients don't like it. So we do need to do better. So what can we do to improve outcomes in IgA nephropathy? So going back to pathogenesis, we can think about HIT1, which is the production of the Gd-IgA1 molecules. Could we use an approach which targets these using targeted steroid within the gut, but with reduced side effects? So Pei, I think this is a really exciting approach to treating IgA nephropathy. What are your thoughts on this?
The new agents based on our understanding of the pathogenesis of IgA nephropathy. So the previous studies found that the genetic IgA1 was produced in distal ileum. So NEFCON was designed to release budesonide in distal ileum. The Navigator study as a phase 3 trial of Nefcan assessed the efficacy and safety in IgA nephropathy after 9 months treatment period and 15 months observational study period. The results demonstrate a significant reduction in proteinuria and a slower eGFR reduction in the treatment group. Based on the above results, Nefcan was approved by FDA and recommended by KDIGO guideline.
Yeah, so as you say, the Nefcan is now in the latest, recently published 2025 KDIGO guidelines, where there's a real emphasis from moving away from just supportive care, but using these evidence-based targeted disease-modifying therapies like Nefecon. The new strategy also prioritizes the concurrent use of SGLT2 inhibitors as well as RAS blockers earlier in the treatment to improve long-term kidney outcomes. Keiichi, based on the latest evidence, what's the impact of SGLT2 inhibitors in outcomes in patients with IgA nephropathy?
As Dr. Wilcox just mentioned, SGLT2 inhibitors have been getting a lot of attention recently. The DAPA-CKD trial enrolled 270 patients with IgA nephropathy from 21 countries. The average age was 51.2 years with an average eGFR of 43.8 milliliter per minute and average UACR of 900 milligram per gram. The mean follow-up period was 2.1 years, and the primary endpoint was composite of 50% decline in eGFR, death, or renal death. In this trial, the dapagliflozin group showed a favorable result with a hazard ratio of 0.23 compared to the placebo group. The incidence of serious adverse events was also lower in the dapagliflozin group at 15.1% compared to 25.6% in the placebo group. After the DAPA-CKD trial with dapagliflozin was published in 2021, the result of a meta-analysis was released in Kidney Week 2022. SGLT2 have a beneficial effect on kidney outcome, and the relative risk from this meta-analysis was 0.49.
So, Dr. Matsuzaki, what can you tell us about sparsentan, also recently approved for its treatment for IgA nephropathy?
The PROTECT trial was double-blind, randomized, active control phase 3 study that involved 18 countries. The left figure shows that the significant reduction in proteinuria observed in the sparsentan group at 36 weeks was maintained through the study. At 110 weeks, the change in proteinuria from baseline was significantly lower in the sparsentan group than irbesartan group. The right figure shows that the chronic slope of eGFR over 2 years was significantly slower in sparsentan group compared to the irbesartan group. Based on these results, sparsentan received accelerated approval from the FDA in February 2023 as a treatment for IgA nephropathy.
It's really exciting that we've got these new treatments for the chronic kidney disease element of IgA nephropathy, and it's helped us to frame the approach to treatment for IgA nephropathy in the context of a new paradigm where we're treating both the chronic kidney disease element and also the immune modulatory element. This graphic nicely shows that our patients, when they come to us, have already lost quite a lot of kidney function. They've already got established chronic kidney disease. So when we're treating them, we need to think about both the chronic kidney disease element using SGLT2 inhibitors and sparsentan, as well as immune modulatory with Nefecon. And in fact, at the moment, there are new drugs coming through targeting this immunomodulatory part of the treatment paradigm. So in the KDIGO 2025 guidelines, there's an emphasis on treating both the production of the abnormal Gd-IgA1 molecules, as well as stopping the inflammation that the immune complexes are causing in the kidney. So we are very lucky in IgA nephropathy. There's lots of drugs coming through which are able to approach these pathways. So there's complement inhibitors which stop the inflammation that the immune complexes cause. And there's also lots of B-cell modulatory drugs which can help reduce the production of the IgA1 molecules as well as the autoantibodies that are directed against them. So thinking about these B-cell modulators, why are they important? Why are they a good approach to treating IgA nephropathy? So B cells are central to the pathogenesis of IgA nephropathy. They act as the primary source of the galactose-deficient IgA1 molecules that drive the disease. So here we have both dysregulated production, so we have antigen-activated B cells, particularly those in mucosal tissues and bone marrow that undergo aberrant glycosylation. This results in the overproduction of these galactose-deficient IgA1 molecules, the key autoantigen in IgA nephropathy. We then have an autoantibody response. So the Gd-IgA1 is recognized by naturally occurring anti-glycan antibodies, which can be IgG or IgA, and form circulating immune complexes. These immune complexes are then deposited in the glomerular mesangium, where they trigger both local complement activation via alternative and lectin pathways, as well as mesangial cell proliferation and activation. And this all results in the release of cytokines and chemokines, which lead to inflammation and progressive renal injury. So IgA production is driven by two key pathways. There's the T-cell dependent pathway, where antigen-presenting cells like dendritic cells process antigens and activate naive T cells, which in turn direct B cells to class switch to IgA production. There's also T-cell independent pathway, where dendritic and other stromal cells directly secrete BAFF and APRIL. These cytokines bind to receptors on B cells, including TAFI and BCMA, and directly stimulate the class switch recombination to IgA. They also stimulate B-cell survival, proliferation, and differentiation into IgA-producing plasma cells. So you can see that BAFF and APRIL bypass the need for T-cell help, enabling rapid mucosal IgA responses, especially in the gut. However, dysregulation of these cytokines is implicated in autoimmune conditions like IgA nephropathy, where overproduction leads to excessive levels of poorly glycosylated IgA1. So targeting BAFF and APRIL is a promising step in the development of new therapies for IgAN. So thinking a little bit more about the BAFF and APRIL inhibitors that we have at the moment, we really have two different classes of BAFF and APRIL inhibitors. We've got sigakibart and we've got cipralelimab, which target predominantly BCMA and the late stage of B cells, and also as well as plasma cells. We also have atacicept, telitacicept and povetacicept, which target both BAFF and APRIL and therefore target a broader range of B cells. Kaiichi, let's talk about cipralelimab, which is a promising APRIL inhibitor in phase 3 trials at the moment. What should we know about its efficacy and safety?
Cipralelimab have shown a strong efficacy in reducing proteinuria and slowing the decline of EGFR. In the phase 2 ENVISION trial, the group treated with cipralelimab 8 mg per kilogram experienced an approximate 60% reduction in proteinuria after 12 months. This group also showed an approximately 65% reduction in serum Gd-IgA1 and significantly slower EGFR decline compared to the placebo group. Regarding the side effects, the incidence in phase 2 trial was slightly higher in cipralelimab group compared to the placebo group. In phase 3 trial, 50% reduction of proteinuria in 9 months interim analysis. The most frequently reported side effect was upper tract infection, which occurred in 70.8% of patients. Dr. Chen, turning to another exciting advance, zigakibart has now entered phase 3 development. What can you share about its emerging efficacy and safety profile?
Zigakibart is an APRIL inhibitor. Results from phase 1 and phase 2 clinical trial showed an significant reduction of proteinuria of 60.4% and stable eGFR. During the follow-up period, they all observed a decrease of IgA, Gd-IgA, and IgM levels with modest reduction of IgG. As to the safety profile, all the participants in the treatment group tolerate during the follow-up, and none patients suffer with TEAE. There are also several dual BAFF/APRIL inhibitors that finish the phase 1 and phase 2 clinical trials, such as tacicept, potacicept, and tacicept. The trials has demonstrated consistent results that was the significant reduction in proteinuria and stable eGFR. At the same time, all these clinical trials demonstrate a favorable safety profile. It's encouraging that all these drugs move on to phase 3 trial. Dr. Mazatsuki, early result from agent Feltamat and Maximat has certainly captured our attention. Could you briefly highlight their impact on proteinuria reduction and renal function preservation?
Anti-CD38 agents which target CD38 protein expressed on mature plasma cells also hold a great promise. Currently, felzartamab is in the phase 2 trial and mezagitamab is phase 1b trial. Following results have been obtained for felzartamab. Sustained reduction in proteinuria was observed for up to 18 months after treatment discontinuation, with the greatest reduction seen after 9 doses. eGFR decline was suppressed. 9 doses of felzartamab produced a long-lasting pharmacologic effect on IgA reduction compared to the recovery of IgG and IgM. Following results have been obtained for rapid and sustained reduction in proteinuria, so week 48, and renal function remained stable, so week 48. So further results are awaited for both drugs.
Thank you both very much. So we've moved from famine to feast in our therapeutic arsenal for IgA nephropathy. But as these new agents become available, the critical question emerges: how are we going to strategically integrate them into our clinical practice? So if we move on to some cases and think about how we can use these drugs in our clinical practice, I'd just like to start with one of my patients who I treated a few years ago now. So back in 2017, a 23-year-old lad came to me who'd just come to do a PhD in Cambridge. And when he presented, he'd had recurrent episodes of visible hematuria in the context of upper respiratory tract infections. And he had quite a lot of blood and protein on the urine dipstick. And already his creatinine was 162 with an eGFR that was already only at 51. So we went on to do a kidney biopsy, and we showed IgA nephropathy with mesangial proliferation, segmental necrosis and crescent formation. There was already segmental sclerosis and more than 50% tubular atrophy and interstitial fibrosis. So giving him an Oxford classification of M1, S1, E1, T2, C1. So both lots of activity and already lots of damage on his kidney biopsy. So when I saw him, his kidney function was deteriorating quite quickly. So we started him on prednisolone to try and arrest this decline in kidney function. And indeed, his kidney function did improve. We started him on mycophenolate and weaned the steroids down, but we still saw a decline in his kidney function. He went into a clinical trial comparing iptacopan to placebo for IgA nephropathy. And during the trial, we don't know which arm he was on, but his kidney function deteriorated. So we pulled him out of the trial and we put him back on steroids and back on his mycophenolate. But you can see his eGFR continued to decline over the next couple of years. And in fact, in 2023, he went on to have a living donor kidney transplant. And he's had a really good outcome. His creatinine currently, his eGFR is 64, and he doesn't have very much proteinuria. But I look back at this and think, oh, you know, we didn't do so well with this chap. Within a couple of years, he lost a lot of kidney function, and you know, he's still in his 20s and he's had a kidney transplant. So just thinking about what we've got and the drugs that we could use now, Pei, if you saw this chap now presenting at the age of 17, what drugs would you like to give him, do you think?
As the novel therapies of IgA nephropathy emerging, we have more options now. I will choose B-cell targeted therapy, like APO inhibitor or dual APO BAF inhibitor.
And what about you, Keiichi? Would you do the same?
Yeah,
Yeah.
almost same.
Yeah. And probably add some sparsentan as well, given that he's already got chronic kidney disease too.
Yeah. I like to share a case from China. It's a 24 years old female, and her complaint is proteinuria. 4 years ago, she found proteinuria with a UTP level of more than 3 grams per day and serum creatinine of 103, and real biopsy was conducted, and it's IgA nephropathy with M1E1 S1T1C2, and the treatment was initiated with valsartan 80 milligrams daily and prednisone 40 milligrams daily, and the steroid was tempered in 9 months. During the follow-up, the patient's proteinuria remains below 1 gram per day. But 2 months ago, the patient took examinations, and the results show that the OTP level returned to above 2 grams per day, and the serum creatinine is 105. At this time, the patient declined to accept serious therapies. So, what should we adjust the treatment next step? The patient initiated dual APO BAF inhibitor this time, and during the 12-month follow-up, it's encouraging to see that the proteinuria reduced from 2.15 to 0.32 grams per day, and the serum creatinine decreased from 110 to 100. So this patient benefited from the B-cell targeted therapy.
Thank you. I mean, I think that's a fascinating case because her kidney function
Yeah.
actually got better when you
Yeah.
treated her, and we're told we need to slow the rate of eGFR slope. But actually, it looks like these drugs might actually be able to improve kidney function a little bit. What do you think? Do you think that would keep going, or why do you think we're seeing this improvement in eGFR?
I think that this patient, maybe a B-cell therapy is effective for her because the urinary protein was gradually decreased after therapy.
And we've seen in the trials that the eGFR slope is improved the most with B-cell depletion compared to the other drugs that are in trials at the moment. So it's really exciting. We've also got the complement inhibitors that are coming through as well, and we've got the better approaches to supportive care. Pepe, what are you thinking about how you're going to use these drugs and when you're going to use them?
I will use supportive care first in patient with stable renal function, but in patients with progressive IgA nephropathy, I will combination of this supportive care and maybe novel therapies such as B-cell targeted therapy or complement inhibitors.
Yeah, so I suppose what we're saying is that you need to look at the patient in front of you, and if they have relatively mild disease, you should manage them with the least that you can in order to reduce their proteinuria and flatten their eGFR slope. But for patients with really aggressive disease, you shouldn't be frightened to use all of these drugs and use them early to stop them progressing to end-stage kidney disease, which is the goal of what we're trying to do. So just to summarize what we've discussed, IgA nephropathy is a disease that affects young people, that a significant proportion progress to end-stage kidney disease, even with relatively low levels of proteinuria. and that we have a lot of new drugs coming through, and we're still working out how we should use them and when we should use them. But we're looking at using them earlier in the disease course to stop progression, and we're looking at targeting both the chronic kidney disease element of IgAN as well as the autoimmune element, and trying to do this at the same time to stop our patients progressing to end-stage kidney disease and needing dialysis or transplantation. Well, I think that's been a fascinating discussion. Thank you so much for your thoughts on treating IgA nephropathy and the new therapies that we've got coming through. And I would just like to finish by thanking everyone for participating in this activity. And please continue to answer the questions that follow and complete the evaluation. Thank you very much.
This program was presented by Medscape Education Global.